Hi, this is Dr. Rauko Chatterjee. Now I'll be talking about hypertrophic pyloric stenosis. Initially, it was known as a congenital hypertrophic pyloric stenosis. It is now a misnomer because it is not found to be congenital. It is now known as an infantile hypertrophic pyloric stenosis or IHPS. The gross appearance of the pylorus in an IHPS is that of an enlarged pale muscle mass, usually measuring 2 to 2.5 centimeters in length and 1 to 1.5 centimeters in diameter. Histologically, there is a marked muscle hypertrophy and hyperplasia, primarily involving the circular layer and hypertrophy of the underlying mucosa. Immunohistochemical analysis of the hypertrophic muscle reveals an increase in fibroblast, fibronectin, proteoglycan chondroitin sulfate, desmin, elastin, and collagen. Confocal microscopy identifies abnormally contorted and thickened nerve fibers. The result of these gross and microscopic changes is either partial or complete obstruction of the pyloric channel. This is a histological picture of the hypertrophic pyloric stenosis, and this is a laparoscopic view of a case being treated for IHPS. The etiology has eluded investigators for several decades, despite considerable research attempting to elucidate the etiology of IHPS. No definitive causative factors have been identified. Both genetic and environmental factors seem to play a role. Evidence for a genetic predisposition includes variability amongst races, a clear male preponderance, an increased risk to firstborn newborns with a positive family history, and certain ABO blood types. Although it is more common in boys, the risk in the offspring of mothers who had pyloric stenosis as infants is greater than if the father had IHPS. Environmental factors associated include the method of feeding, breastfeeding versus formula feeding, seasonal variability, erythromycin exposure, and transpyloric feeding of premature infants. Now, certain growth factors and gastrointestinal peptides have been involved. Over the past several decades, these are implicated by direct or indirect methodologies as having a causal relationship. These include gastrin, substance P, epidermal growth factor, transforming growth factor alpha, insulin-like growth factor 1, somatostatin, secretin, enteroglucagon, and neurotensin. Other peptides have also been evaluated. So substance P, which is a neurotransmitter responsible for the enteric muscle contraction, could produce chronic pylorospasm leading to muscle hypertrophy. Neurotrophins, neural development and nerve function. Neurotrophins, which are important for nerve differentiation and survival, have been noted to be decreased in IHPS. Further studies have shown that one of the specific receptors for these neurotrophins, the tyrosine kinase A receptor c-KIT, is not present in the IHPS tissue. The pylorus is deficient in glial-derived growth factors, which may be indicative of immature development of the enteric nervous system. Pietrovska and colleagues found that muscle biopsy specimens from these IHPS patients have decreased numbers of interstitial cells of Kajal, which are known as the pacemaker cells for the GI tract. A lack of heme oxygenase 2, which may play a role in communicating between the interstitial cells of Kajal and smooth muscles, have also been discovered. Coming to the clinical findings, these include the onset of non-bilious vomiting at 2 to 8 weeks of age, with a peak occurrence at 3 to 5 weeks. Two reports are at variance with traditional concepts. Those are that IHPS has been diagnosed at birth and even in utero. Initially, the emesis may not be frequent or forceful, but over a period of several days, it progresses to nearly every feeding and becomes forceful or projectile. This is a small comic to illustrate this. So this is a diagram summarizing the clinical signs. So you can have signs of mild to moderate dehydration, indicative by sunken fontanelle and dry tongue, projectile non-bilious vomiting, a hungry active baby except in very advanced cases, a palpable pyloric tumor which feels like an olive or marble, visible peristalsis over the stomach, and dry nappies, constipation. On occasion, there may be blood in the emesis that gives it a brownish discoloration or a coffee ground appearance as a result of gastritis or esophagitis. Infants with IHPS remain hungry after emesis and are otherwise not ill-appearing or febrile. A significant delay in diagnosis leads to severe dehydration, however, results in a lethargic infant. Some infants have diarrhea, that is starvation stools, and are thought to have gastroenteritis. Pylorus spasm and gastroesophageal reflux may be difficult to differentiate from IHPS without further imaging evaluation. Other medical causes of non-bilious vomiting include gastroenteritis, increased intracranial pressure, and metabolic disorders. Other surgical causes of non-bilious emesis include antral webs, pyloric atresia, duplication cyst of the antropyloric region, and ectopic pancreatic tissue within the pyloric muscle, all far less common than IHPS. Let's talk about the diagnosis. Non-bilious projectile vomiting, visible peristaltic waves in the left upper part of the abdomen, and hypochloremic, hypokalemic, metabolic alkalosis are cardinal features of IHPS. A definitive diagnosis can be made in 75% of infants by careful physical examination of the upper part of the abdomen. Frequently, imaging procedures are requested by primary care physicians in lieu of a careful physical examination. So it is very important to palpate the abdomen. To be successful in palpating an enlarged pylorus, the infant must be calm, warm, and cooperative. The use of a pacifier or small feeding, that is 5% dextrose in water, may be helpful. If the stomach is distended, aspiration with a nasogastric tube assists successful palpation of an enlarged pylorus, often referred to as the olive. With the infant supine and the legs bent to relax the abdominal muscles, the examining hand should be placed on the epigastrium. After the edge of the liver has been identified with the fingertips, gentle pressure deep to the liver, progressing caudally in the midline, a third of the distance between the umbilicus and the xiphoid should reveal a palpable mass if IHPS is present. To commit 5 to 15 minutes of uninterrupted time, if necessary, to obtain an adequate examination must be given. One should be able to roll the hypertrophied pylorus under the fingertips to be convinced of the diagnosis. Ultrasound has not only become the most common initial imaging technique for the diagnosis of IHPS, but also the standard. Under optimal circumstances, this technique is reliable. However, it is dependent on the level of experience and expertise of the radiologist. The generally accepted criteria for a positive ultrasound study are a pyloric muscle thickness of 3.5 to 4 mm or more and a pyloric channel length of 16 millimeters or greater. Some centers also determine pyloric diameter and consider more than 14 millimeters to be abnormal. This is how the measurements are done on the ultrasound. This is showing the pyloric thickness. If ultrasound is not available or diagnostic, an upper GI contrast examination is highly effective in making the diagnosis. Barium is generally preferred compared to water-soluble contrast to avoid the chemical pneumonitis should aspiration occur. This study should demonstrate an elongated pyloric channel and indentation on the antral outline, which are indirect findings of pyloric muscle enlargement. So you can see this is the stomach, which is dilated, and there is a narrowing here. So this is the hypertrophied pylorus, and this is the thin stream of dye which is passing through. Paradoxical aciduria. Hypochloremia and hypovolemia stimulates the aldosterone, which occurs due to the vomiting. So when it is stimulated, it promotes sodium absorption in the distal convoluted tubules of the kidney. Sodium is getting absorbed in the distal convoluted tubules. Normally, sodium is exchanged for potassium. However, potassium is concurrently depleted, that is, it moves intracellularly in exchange for hydrogen in an alkalemia because there is alkalosis, and it is lost in gastric secretions, which this is also decreased intake due to the anorexia. So, sodium is exchanged, it is resorbed for hydrogen, which is excreted into the urine. This causes a paradoxical aciduria. We would expect acid to be conserved, but it is excreting acid, right? Preoperative preparation in the treatment, it has to be done carefully. The infant has to be prepared adequately for the anesthesia as well as the surgical correction. The length of preparation depends on the severity of the fluid and electrolyte abnormalities. Benson and Alpern defined 3 levels of severity based on the serum based on the serum carbon dioxide content. These levels are slight, moderate, and severe. Now, if the serum carbon dioxide content is less than 25 milliequivalents per liter, it is slight. If it is moderate, it is between 26 to 35 milliequivalents per liter. And if it is more than 35 milliequivalents per liter, it is severe. In addition to the elevated bicarbonate, hypochloremia, hypokalemia, dehydration, and possibly malnutrition may be present. Fluid resuscitation should be based on the degree of dehydration and the extent of the electrolyte abnormalities. Most infants with IHPS should be able to be resuscitated within a 24-hour period. So, the operative procedure of choice remains the Ramsted's pyloromyotomy. Initially, Fredette had described a pyloroplasty. So, what he had done is, after exposing the olive, he had incised and closed it transversely. Serendipitously, Ramsted, during a surgery, could not close this due to some reasons, but he found out that the patient had improved. From there, it has become the gold standard to not resuture the incision and to just leave it as a pyloromyotomy. So, in this, the muscle is incised up to the prepyloric vein. It is carefully seen for the movement of both the upper and lower lips of the pylorus should be moving independently. That indicates a complete pyloromyotomy. What has to be also checked for is whether there is any perforation of the mucosa or not. If that occurs, this incision is closed and the procedure is repeated on the posterior aspect of the pylorus. This is a photo showing a laparoscopic pyloromyotomy which has been done. Here. So this is what I was telling you about. Okay. So the open technique, the standard open approach is a right upper quadrant transverse incision of approximately 2.5 to 3 centimeters made either over or lateral to the right rectus muscle and just superior to the edge of the liver. A commonly used alternative is a supraumbilical curved skin incision followed by division of the midline fascia superiorly for 1 to 2 centimeters. So in this, this alternate incision, supraumbilical incision is placed just above the superior border of the umbilicus, and subcutaneous dissection is done, and the sheath is opened actually vertically for about 1 to 2 centimeters. This gives adequate access to the peritoneal cavity. This is the position of a laparoscopic IHPS procedure. So as you can see, the pylorus is grasped and a knife is used to cut it. Following this, a Maryland forceps or a pyloric spreader is used to spread the pylorus. This is a feeding schedule post-pyloromyotomy. Complications: vomiting frequently in the early post-op period is thought to be secondary to the gastroesophageal reflux, discoordination of gastric peristalsis, or gastric atony, and should not be considered a complication. Frequent vomiting persisting beyond 3 to 4 days may suggest an incomplete myotomy or an unsuspected perforation. A post-operative contrast study may demonstrate a leak, but is not helpful in evaluating the completeness of the myotomy. It takes several weeks for radiographic appearance of the pylorus to improve. Persistent and frequent vomiting 1 week beyond the pyloromyotomy may require re-exploration. Let's have some questions. Which of the following is true regarding hypertrophic pyloric stenosis? The answer is B. Premature infants are diagnosed later than post-term or term infants. Which of the following is true regarding the metabolic derangement seen in hypertrophic pyloric stenosis? The answer is hypochloremia. Which of the following is true regarding management of IHPS? Postoperative MS is a common occurrence and can occur in up to 80% of cases. Thank you.